We'll just give a couple of minutes for people to join in, and then we'll kick off. Right, another 30 seconds, and then we'll start. Right, a very good evening, ladies and gents, and welcome to the 4th episode of the British Hip Society Midweek Special. I'm Vikas Kanduja, consultant orthopedic surgeon in Cambridge and chair of the Education Academy in the British Hip Society, and it is indeed a pleasure to welcome all of you to this webinar. Now, our aim with this series is to bring to you clinical cases and discuss nuances of decision-making and management from key opinion leaders in the field of hip surgery in the UK, so that we can continue to fulfill the Society's manifesto of sharing knowledge and improving patient care. We've had 3 excellent sessions on primary total hip arthroplasty, and the session today will be focused on femoral neck fractures. Moderating the session today would be Professor Mike Reed from Northumbria, with stellar faculty including Mr. Kiran Singhi-Sethi, Mr. Jaya Palan, and Mr. Martin Parker, and I'll let Mike introduce them to you in a minute. We're also delighted to be collaborating with OrthoTV Global for this series and welcome all the viewers from the Asia Pacific region who are able to watch this webinar streaming live at no cost via OrthoTV. Thank you very much, Ashok, for the same. We strive to make each session as interactive as possible, and therefore please do post in your comments and questions in the Q&A box. Our panelists will address these questions as we go along and choose some of them to discuss live at the end of the webinar. For those of you who are not able to join us live, we do have the option of on-demand viewing via our educational platform, Panopto. So please do log in if you've not been able to watch this live today. Finally, a big thank you for nominating us in the Best Webinar Series for the BOTA Awards, and please do continue to support us by casting your vote as well. Once again, a very warm welcome to all of you, and hopefully you'll enjoy this series. Over to you, Mike. Thank you.
Thanks, Vikas. So welcome to this midweek special on femoral neck fractures. Thanks, Vikas. So welcome to this midweek special on clinical scenario. Our National Hip Fracture Database in the UK reports around 200 cases a day. And the aim of today is to tease out tips and tricks from our faculty so that we can do better as a group. So we know that pre-COVID, there are some 6.5% of patients who will die within 30 days of a hip fracture. And according to the Model Health System, or the Getting It Right First Time data, around 2% of our patients will return to theatre within a year. And perhaps there's room for improvement. So I don't think any series on acute femoral neck fracture would be complete without our next speaker who's opening today, and that's Martin Parker. So Martin is an orthopaedic surgeon, but he's got a special interest in the treatment of hip fractures, and he has a unique job, actually, which involves the complete care of patients with a hip fracture, through from the assessment at the time of admission, through surgery, post-op care, rehab, and into outpatients. He's the author of 2 textbooks on the management of hip fractures, and has written a staggering 18 Cochrane reviews on the topic. There's got over 200 journal articles on hip fractures. So, Martin, if I can call on you to share your slides and tell us your tips and tricks based largely around choice of implant.
Thank you very much, Mike, for the kind introduction. And I'm always a bit wary of these things. Just give us a quick wave to say that you can hear me okay and everything's working all right. Really good.
We can hear you perfectly.
I'm just going to run through quickly this. I've got a little bit of conflict of interest here on choice of implant because this is the one that I developed for intercapsular hip fractures. So just bear that in mind as we go through. So let's just very quickly divide how we're going to work this for the seminar. Intercapsular versus extracapsular, that's straightforward. Then divide your intercapsulars to undisplaced versus displaced. And your extracapsulars are essentially your trochanteric and your subtrochanteric. So that's just your basic classification of how we're going to be working on things. So undisplaced intercapsular fractures, and again, it's slightly a vague term here because on the left you say that's undisplaced, slightly impacted, but on the right it's beginning to displace. And your old-fashioned garden classification just looked at the AP, they didn't look at the laterals, and so you can get quite a bit of displacement. And in fact, for intercapsular fractures, there's a range of displacement occurring really from totally, completely undisplaced to a little bit to opening up on the lateral a bit more to becoming completely displaced. And where do you divide your line between undisplaced and displaced is somewhat questionable. And so you might term them partially displaced. And that's why there's a bit of vagueness here. So the old classification essentially was just on the AP, and undisplaced was undisplaced or impacted. And then once it had gone and opened up and displaced, it was called displaced. So a little vague, really. You are open to some interpretation here. Your standard treatment for your undisplaced intercapsular fracture is to fix it. And your most common things are multiple cancellous screws or your sliding hip screw. And this here is the Cochrane review looking at all the randomized trials that compared the screws versus the sliding hip screw. And essentially, there's not a lot of difference. Slight favor towards the sliding hip screw. And the big trial is the FAITH trial there with the 1,000-odd patients, essentially showing not much difference between slip screws and a sliding hip screw. Cochrane review on this is just being updated on this, as are all the Cochrane reviews. So we can reassure ourselves we're going to fix it and it doesn't make much difference, multiple screws or a sliding hip screw. If we look at the literature over the years and more recently, things are going wrong with our undisplaced fractures and your overall complication rate is gradually getting bigger and bigger. And now it's up to about 20% non-unions, AVNs for undisplaced fractures. And that's because our patients are older and frailer and more osteoporotic. The fixations aren't working as well. And quite reasonably, people have said, well, perhaps we should arthroplasty them. And this is the randomized trial from Norway looking at this, 220 patients randomized undisplaced fractures to multiple screws or to a cemented hemiarthroplasty. The overall thing, there wasn't much difference in the outcome. Functional results were pretty much the same, but a lower reoperation rate for the arthroplasty, 21% after internal fixation. So suggesting things are moving towards arthroplasty for these fractures as our patients get older and frailer and our complications go up. My alternative is to try and use a better implant, gain conflict of interest here. It's not the only implant that's been around that's developed that's a sort of hybrid sliding hip screw, cancellous screws, but suggesting it will reduce your rate of non-union. No effect whatsoever on AVNs, but will perhaps reduce your non-unions by around a third. But there are other implants beside mine looking at this, trying to reduce the failures. Move on, got to go quickly through this really, displaced intercapsular fractures. So we're going to generally treat these by arthroplasty. But we've got to bear in mind, you've always got to look at that patient and get a rough idea how long they're going to live. And if you think they're going to live longer than that arthroplasty, then perhaps think about an internal fixation. And so you change over at around the age of 60 to 65, but that's a bit vague. It's more physiological rather than chronological. So if you think they're going to live more than 25 years, you've really got to be thinking fixation rather than arthroplasty. And I know we'll all debate amongst ourselves how long our hip replacements last, but this is the Evans article from the Lancet. Some of you might not like it. A 42% revision rate for 25 years for total hip replacements, and this is based off registry data. So if you've got your patient age 60, you think they're going to live to the age of 85, that's 25 years, then you've got to counsel them and say there's roughly a 42% revision rate. And in actual fact, it's higher than that because your arthroplasties for hip fractures don't do quite as well as your arthroplasties for your arthritic patients. So it's probably 50% by 25 years for your hip fracture patients. So you've got to work into that really. You can say, okay, fixation's got a high failure rate, but so too is the arthroplasties. If we are going to put an arthroplasty in, these are the questions you want to ask yourselves: unipolar versus bipolar, total hip replacement versus a unipolar, or cemented or uncemented. That's the questions we've got to ask ourselves. We can pretty quickly deal with unipolars versus bipolars. There's a Cochrane review on it, 12 randomized trials. It's not a lot, only 1,400 odd patients randomized, unipolar, bipolar. No major differences between the two, but it's very limited evidence, limited follow-up. We really don't know. And so until we do know, then just go for the simplest and the cheapest. That's the unipolar. So we can quickly just throw away our bipolars for the present time, not proven to be any value, and they are more expensive. Total hip versus hemiarthroplasty, a lot of talk about this. So the NICE guidance is fairly clear. And basically it says you should offer to the patient who is in this criteria, minimal use of walking aids, fit for the procedure of total hip, cognitively intact. But the question is that supported by the evidence? Why did they come up with this statement? Well, at the time they made the NICE guidance, we were back about 2010, and they were looking at all the early randomized trials which favoured total hip. But they were quite a selected group of patients, those 6 randomized trials at the top, really. So the biggest one was the STARS, the Scottish study, randomized patients, but it only randomized 200 odd patients, and they'd screened 2,684 patients to randomize the 200. This is a highly selected group of patients. And if you look on the screen there, the early trials tended to be the younger patients, the more fitter ones. The bigger trials came on later, and particularly the health trial that's just come out, a wider category. And the ones down the bottom were more the NICE criteria, sort of admission to the trials. One's a broader one, older group of patients, and they all came out favouring hemi. So this is where the controversy is really getting a little tricky, is how to interpret. But essentially, is what we're saying is that there is definitely a group of patients who are better off with a total hip, but it's not the NICE guideline criteria. It's actually a younger, fitter group of patients than NICE would like us to think we should have. And it's probably only somewhere between 10 to 20% of our displaced intercapsular fractures need a total hip. The rest, you're okay for a hemi. So only appropriate for the fitter, active ones aged around the 60 to 75. Younger than that, you go for the fixation. Older than that, you go for the hemi. Roughly 10 to 15% of our displaced intercapsular fractures. If you are going to do a total hip, then consider you may need to adjust your surgical technique, less invasive, maybe more like anterior lateral approach to minimize dislocation, and think about your bipolar heads and your that sort of thing to reduce your dislocation rate. So move on a little bit. That's whether we're doing a total hip or a hemi. Cement. Do we cement them in? NICE is very clear on this. There's not much. Just says cement them in. That's it. That's NICE. Let's just look at the evidence that NICE used for this, really. And this is a summary of the randomized trials, as from the Cochrane database, looking at the difference between cement and uncemented within the trials. So if you put an uncemented one in, you'll increase your operative fracture of the femur up to 5%. You'll increase your risk of later periprosthetics fracture up to 6%. Because of that, periprosthetic fractures, you'll increase your reoperation rate for the uncemented ones. There is a lower one-day mortality for your uncemented. We've got to say that definitely is. But by 1 year, if anything, the mortality is slightly increased for your uncemented because you've got a higher fracture complication rate and revision rate. Your uncemented ones are more likely to lead to residual pain, particularly for the Austin Moores, not so much for the modern ones, it's felt to be, but for all of them, you'll get better regain of function for the cemented ones. So everything in favour of cement, apart from that one-day mortality. And what's the problem? Why do we get that one-day mortality? It's this combination of embolizing the marrow contents as we ream out the femur and put the prosthesis in, and then In addition to that, put in the toxic aromatic hydrocarbons with the cement. And in about 1 in 200 patients, you'll send them into asystole and they'll die. So this is a major worry and complication. We've just got to reassure ourselves really that, okay, we've upped our 1-day mortality, but by 1 month, in fact, by 2 days, that difference in mortality is gone. And by 1 year, if anything, the mortality is slightly better for your cemented implants because you put in a better hip for them with a lower chance of coming back in. So that's how you've got to justify to yourself, to your anaesthetist, to your patients, why you want to cement them in if at all possible. Move on, extracapsular fractures now. The big debate, of course, is do we nail it or do we put a plate in? Now, we've got nice guidance again, really. It just says put a plate, but we've got to question that, really. The Cochrane review is now being updated. Lots more randomised trials. This is good evidence base here. This is 10,000 odd patients randomised, and the Cochrane review is showing this. And what does it show? Essentially, there's no difference between the nail and the plate for these things listed here: post-op complications, re-ops, transfusions, deep wound infections, hospital stay, mortality, and residual pain. No difference. But, and this is just taken from the Cochrane review, and the reason why Cochrane said don't use the nail is for the early randomised trials, they definitely favoured the sliding hip screw, no doubt about it. 9% versus 4% failure rate. But if you look at those more recent ones, all the nails have been designed. We no longer use the old Gamma 1 nail. Everything's been modified. So now for the more recent randomised trials, failure rate is equivalent between the two, nails versus sliding hip screw. So we know we've got no difference in our failure rate, but we do have some definite advantages coming out for the nail: reduced superficial wound infection, shorter duration of surgery, but most important of all, better regain of mobility for those treated by the nail. And you can look at these, and some of the studies show this. You can get less fracture collapse if you put the nail in. You put a big chunk of metal actually in the fracture side. It reduces the collapse that you get. You get a better regain of function. The more anatomical you can get these fractures to heal, the better will be your gain of function. What about these difficult fracture patterns here? Transverse fractures, A3 fractures, reversed fractures at the level of the lesser trochanter. And these are the difficult ones with femoral medialization, pulling the plate off, causing excessive fracture collapse. So in these, you can still use a sliding hip screw, but the nail's got the potential advantages of putting that chunk of metal in there, and you can get sliding both along the line of the lag screw and also along the dynamic distal one. So nail theoretically is beneficial here. So you do get less collapse and less medialization with a nail. There are alternative implants you can use. Some people may have seen this. Is a trochanteric stabilizing plate designed to go on to reduce the amount of collapse at the fracture site. Being used quite a lot, but very little published about it. We just don't know whether it is beneficial or not to reduce the collapse because of the limited published evidence. This is an implant not to use. This is the dynamic condylar plate, or you can use a blade plate. And we've got case series reports, 3 randomised trials, all showing markedly increased failure rate if you've got these difficult fracture patterns and then try and fix it with a blade plate or a fixed dynamic condylar screw. You will dramatically increase your failure rate. These plates have got no place whatsoever for the primary treatment of a hip fracture. And there's a few others around on the market that have been tried, but still not proven to be of value, like the Medoff plate, the percutaneous insertion plate, and the trochanteric external fixator. Some randomised trials, they're summarised in Cochrane reviews. None of them shown to be better than the sliding hip screw or the nails. Some people use arthroplasty for this fracture, and it's reported in quite a number of case series and 2 small randomised trials. We just don't find enough evidence to support its use at the present stage. Just a little word about subtrochanteric fractures. Yes, generally put a nail in these, closed reduction and put a nail in these. Expect potentially more difficult surgery. We really don't know whether you should be doing open or closed reduction on these. The role of circulage wire, is it more beneficial or not? Because you've got to expose the fracture and tissue dissection. So there's a lot of unanswered questions here. We just don't know for sure. So that's just a very quick summary through on hip fractures there and the implants to use.
Martin, that's absolutely fantastic. If I can just ask you to unshare your screen. But While you do that, I'm going to ask you a question which has come up in the Q&A, and it's not directly about implant choice, but I think you're probably extremely well qualified to answer it. The question is anyone using a posterior approach for hemis, or are people waiting for the extra spare approach? So have you got a view on that, Martin?
Yeah, well, you can use either, and I did the randomised trial on posterior versus anterolateral. There's not a lot of difference between the two, but you will increase your risk of dislocation. So if you're using a posterior one, bear that in mind. Careful capsular repair going in posteriorly. I used piriformis preserving when I was doing posterior ones as well, but it makes it technically a bit more fiddly. But posterior is okay, but generally speaking, anterolateral, and particularly for your trainees and anterolateral, because it's got the lower dislocation rate. So I've got no big views saying you can't use posterior, but just bear in mind that there's potentially more dislocations will appear. Yeah.
Okay. All right. So I think our next speaker may cover some of that. Our next speaker is Kieran Singasetti, who actually trained here in the Northeast and then went on to do two very prestigious fellowships, the first being the Cavendish in Sheffield, and then he went on to Mass General in Boston to do trauma. So he's got a practice of hip and knee revision and trauma, and he also leads on hip fracture for his organisation. So very well qualified to give a talk on this topic. Kieran is going to talk to us today about complications of hemiarthroplasty. So welcome, Kieran, and if we can hear from you, that'd be great.
Thank you, Mike. So I've been asked about talk about complications of hip hemiarthroplasty. So just to give you a context around reoperations for hip fractures in general, this is a slide from the National Hip Fracture Database, which reports a 1% reoperation rate within 120 days. Some consider this as an underestimate because obviously it only considers only the 120-day reoperation rate. And also, like any registry data, the accuracy depends on the input of the data. Nevertheless, it's a useful chart to look at for individual units. You can audit it, you can reflect, come up with some improvements. So just to give you an example, this is a graph for my unit. Around 2018, we had an issue with an upward worrying trend for reoperations for hip fractures in general. We did a roundtable MTT style meeting with multiple staff, including nurses, consultants and trainees, and came up with some suggestions looking at each cases. And you'd see that the graph now looks more favorable, just proves the point that a lot of risk factors related to reoperation can be mitigated and you can make improvements. So what is the reoperation or revision risk with arthroplasty for hip fractures? This paper from ACTA in 2018 looks at this specific issue, looking at more than 30,000 patients from the Dutch arthroplasty register. The one-year revision rate for hemiarthroplasty is about 1.6%, and this increases to about 2.4% in the total hip group. In general, the risk factors for revision for an arthroplasty around for hip fracture is age and this 80, posterior approach, as we just discussed, uncemented stems, and male sex. Now, looking at the dislocated hemiarthroplasty specifically, this is one of the commonest reasons for reoperation following hemiarthroplasty. Just to give you a couple of examples, this patient underwent a hemiarthroplasty, did well, went home within the first week, but sadly represented following a fall 6 weeks later. Patient went to a theatre, was reduced under anesthetic. Fortunately, on this occasion, the hip turned out to be stable and the patient didn't need any further procedures. In my experience and in generally our experience in the unit, MUA of a hemiarthroplasty is rarely successful. It eventually may need more procedures in long term. Another example, this patient underwent a hemiarthroplasty. You can argue whether the fracture extends into the trochanteric. Could a different implant be used? Nevertheless, they had a hemiarthroplasty and represented 3 weeks later with a dislocation. This time, the x-rays were more obvious that the fracture involves the trochanter. Went on to have a revision with a trochanteric plate and a constrained liner. This is a patient who had a constrained liner. Our unit has looked at a series of constrained liners for dislocated hemiarthroplasty. Generally, mortality is very high, as you would expect, but they probably do all right if you look at the revision risk. Are there any risk factors for a dislocation of hemiarthroplasty? Yes, there's some papers looking into this specific issue, and this has been just covered by previous speaker about that approach for hemiarthroplasty. Posterior approach has a slightly higher risk of dislocation compared to your anterolateral approach. There are other risk factors, but it's mainly technical, according to this Scandinavian paper, which looks at, again, a group of dislocated hemiarthroplasty. So it's less of anatomical issues related to patient, but more of technical issues with how you do the hemiarthroplasty, which makes the risk of dislocation. Now, how does it matter if a hemiarthroplasty dislocates? Well, the outcomes are generally poor. There's a very high mortality rate. This paper from 92 in injury quotes close to 65% 6 months mortality rate. More recent papers from Martin Parker's group describes a similar kind of high mortality rate, possibly better than what was previously quoted. Again, a closed reduction is generally unsuccessful, as our experience has been, and most of the hip hemiarthroplasty dislocations happen in the first 4 to 6 weeks. Now, can you mitigate the risk of dislocation? Yes, you can. As again, we touched upon this a little while ago, a good capsule and abductor repair is crucial. Can't overemphasize checking the stability after reduction, careful assessment of your preoperative x-rays, templating sometimes does help this, and restore your anatomy looking at the unfractured hip. Avoiding excessive anteversion if you are, as vast majority of people may be using an anterolateral approach. A couple of papers looking at the importance of templating for hemiarthroplasty. Both papers highlight that it focuses your mind. It helps to identify uncommon head sizes, anticipate narrow femoral canals and anatomical issues around it. It's less commonly practiced when you compare it to your elective joint replacements. Moving on to your second group of patients who have reoperation following a hemiarthroplasty, it's a periprosthetic fracture. They can be your intraoperative, early postoperative, or late postoperative fractures. So for example, this patient of mine who presented about 8 years following a hemiarthroplasty, they had pain in this hip before they fell. So we looked at the x-rays, figured out that it's a loose hemiarthroplasty with some osteolysis. So went ahead to revise it into a long stem modular revision with a dual mobility cup. Patient did well for the first couple of weeks, went home, but sadly died in the 3rd week. This proves the point that this group of patients are quite frail, elderly, and they have a high mortality rate. And unfortunately, it counts as a 30-day mortality for your National Joint Registry. Another x-ray, limited fixation in periprosthetic fracture for this elderly group doesn't really work because patients generally struggle with restricted weight bearing. So just be cautious about it. Otherwise, the principles of fixing this is pretty much similar. So you would fix a B1 or a C fracture and replace with a long stem modular revision or a cemented revision if it was needed for your B2 and B3 fractures. Now, we've covered a little bit about this early on, difference between cemented and uncemented hemiarthroplasty. The Dutch arthroplasty register looks at this in this paper. There is an early slight increase in mortality with the cemented within the first 24 hours, but beyond that, there's probably not much of a difference in terms of the mortality. but there is an increased revision risk. So the red line shows the uncemented stems, which have a significantly higher risk of revision compared to your cemented group. And other papers have looked at this, including the more recent from the Norwegian hip fracture register, which quotes about 2.1 times risk of revision with an uncemented hemiarthroplasty when you compare it to a cemented stem. Now, the Norwegian hip fracture registry looks at more granular detail, and again, a similar paper from them in BJJ looks at what type of stem is favorable in the cemented group. So when you look at individual cemented stems, they feel that the anatomical design of stems, such as a luminous, has more favorable risk profile for periprosthetic compared to your polished taper stems. This brings to the third group of patients who might run into trouble with a hemiarthroplasty, as in have an infection. Again, infection, whether it was a hemi or any form of hip fracture surgery, is quite challenging to treat. Just to cover a couple of examples, this patient presented a few weeks after a hemiarthroplasty, had an infection, which turns out to be an enterococcal infection. Patient was pretty frail, had a first stage with a good clearance of cement, and was planned for a second stage, but sadly never made it to the second stage. This is another patient of mine who was waiting for a hip replacement on the right side, had a hemiarthroplasty for intracapsular fracture, sadly presented with early infection, but settled down with DARE as it was a sensitive coagulase negative Staph aureus. Now, what is the problem with surgical site infection in hip fracture surgery? Well, this meta-analysis looks at specifically this issue. 20 studies looking at about 88,000 patients. The overall incidence is about 2.1%. And if you look at hemiarthroplasty as a group, it's about 2.87% and slightly less in the sliding hip screw group. Now, can you predict the risk of infection? Are there any specific risk factors for infection following hemiarthroplasty? Again, these two papers look specifically at this issue. You can look at the risk factors as preoperative, not that there's a lot you can optimize the patients, as with any trauma patients, you haven't much time to do it. Operative and post-operative risk factors are the ones you can help with. The duration of surgery, the level of experience of the surgeon, post-operative hematoma, wound drainage, all kind of add to the risk of hemiarthroplasty-related infection. A very short operation time, which is less than 45 minutes, or a long operation time beyond 90 minutes, kind of increases the risk of infection. So you've got to find a sweet spot to do your operation carefully, meticulously, but not spend too much time with these. Now, what are the treatment options for an infected hemiarthroplasty? Well, the results generally are not great. Their success rate has been quoted between 22 to 44%. And in general, this poor kind of results when you compare to your DARE success rate in your elective joint replacement infection patients is because of the host factors, because the patients are generally frail. And they can have polymicrobial infections, including enterococcus. Now, can you mitigate any of these risk factors? How can you reduce the risk of surgical site infection? Well, this paper from Mike Reed's group in 2016 has given some useful information for us. Using dual antibiotics loaded cement reduces the risk of infection to about 1.1% when you compare it to the control group, which is close to 3.5%. We've been an early adopter of this practice, and so are other hospitals in the region and across the country now. Now, a lot of failed hemiarthroplasties or complications related to hemiarthroplasty do convert to total hips. So is total hip replacement a panacea for a complication following hemiarthroplasty? Not really, because this group of patients continue to have this problem. They have a very high risk of reoperation rate. Now, this is a paper from the Mayo Clinic group looking at more than 380 patients over a 30-year period for failed hemiarthroplasty, which got converted to total hips. And they continue to have a high risk of reoperation, and needless to say that they have a high mortality. So it begs the question whether a revision of a hemiarthroplasty to a total hip is or should be considered as a primary joint replacement. So to summarize, complications following hemiarthroplasty is challenging to manage. Early intervention for instability and infection is needed. Obviously, you've got to consider your patient in general, the physiological status, because they're not as fit as your elective patients. Cemented hemiarthroplasty has a lower risk profile for periprosthetic fracture compared to your uncemented. Outcomes are generally poor once you come to a reoperation following hip fracture surgery. So prevention is the key. Getting it right the first time, as we say, is probably the answer to this. Thank you.
Kieran, thank you very, very much for that, and very wide-ranging talk. So can I just ask you a question while our next speaker is loading slides? So you mentioned doing a DARE there, and obviously we've got a monoblock implant in many cases, or sometimes a modular implant. Do you ever change the implant when you're doing that first debridement, or are you always just retaining the implant? Well,
that's a good question. So for a DARE, we would normally change a modular implant, or if you consider a polished tapered stem, we use an Exeter trauma stem. So it's easy enough to change the stem. But if it was difficult to do with other related hemiarthroplasty stems, then you probably retain it. So there is not much of literature whether retaining the stem or changing the stem makes a difference. But in my practice, if it is an ETS, I do tend to change or exchange the stem.
Yeah, it seems like a logical step when it is very easy to get out, I think. So thanks for that. I'm going to introduce our next speaker now, and this is Jaya Palan. So I first met Jaya actually when he was a lad, and when he was president of the National Orthopaedic Trainees Association, and he went on to be a National Joint Replacement, a National Joint Registry Fellow. But he subsequently completed fellowship training in Nottingham and Coventry and Oxford, and he's now a consultant in Leeds, and he's got an interest in primary and revision hip and knee, and in fixing periprosthetic fractures. And this year, he's the BHS choice for the BOA Future Leaders Programme. So, Jaya, take it away. What happens when what fixation goes wrong?
Thank you very much, Mike. I hope you can all see the screen sharing. So we've heard fantastic talks about what happens when we have these patients who are elderly, who have fractures that go wrong, that are fixed, but what happens when it does go wrong? And we've heard the complication rates can be quite high. I should state I've got no conflicts of interest and nothing to disclose. So what is fixation failure? Well, fixation failure can really be any of these causes. Non-union, avascular necrosis of the femoral head. The implant may either cut out or penetrate through the femoral head, or indeed the implant may break. The implant may detach from the femur. You may have an intraoperative fracture of the femur, or indeed a delayed fracture down the line of the femur. The incidence of failure is quite high. You can see here some papers have shown that if you have an intracapsular fracture, which is undisplaced, the incidence of failure is almost 15%. But if it's a displaced fracture that's been fixed, it's almost 40% plus. Now, if you fix an extracapsular fracture, either with a dynamic hip screw or an intramedullary nail, it's approximately 7 to 14% for either option. So as Martin Parker stated, there really probably isn't a huge amount of difference between fixing extracapsular fractures with a DHS or a nail. I think it's very important to consider why the fixation has failed. And I've split this into really host factors, the fracture personality, and indeed the surgeon or technical factors. And host factors often are because these patients are elderly, have compromised physiology and bone biology. They may be young patients with high energy trauma with significant periosteal stripping, which compromises the blood supply. The fracture personality is important. It may be comminuted, difficult to reduce, close, subtrochanteric or transverse fractures, which makes reduction difficult, or indeed pathological fractures, which have a higher rate of non-union. And finally, the surgical factors. We need to decide whether or not the implant of choice is appropriate for the fracture type. And there is a gray area, these sort of, sort of pertrochanteric type of fractures, which may extend from an intracapsular to an extracapsular fracture pattern, can be difficult, or subtrochanteric fractures. And obviously things like the tip apex distance and where you place the lag screw, etc., are important. The biomechanical instability because of inadequate fracture reduction can lead to failure. And indeed, the fracture biology may be compromised by what we do, either open reduction or indeed the use of cerclage wires or cables, which may constrict the periosteum and therefore the blood supply. Always think of infection. Infection should always be at the back of anyone's mind when something fails, and it's appropriate to do the necessary screening tests for this, and if unsure, to get samples for certain. So really, there are two main options. We can either refix the fracture, or we can go to conversion arthroplasty, and that's either hemiarthroplasty, a total hip replacement, or indeed, perhaps more commonly now, there's a trend to maybe considering proximal femoral replacements. This was an article in BMC musculoskeletal disorders quite recently, looking at the strategy for treating failed fixation of intratrochanteric fractures, and it is very much weighing up whether we do a salvage refixation versus conversion arthroplasty. And there are really 5 things here: the physiological age of the patient, not the chronological age, the life expectancy of that patient, the bone quality, whether or not the hip joint has been affected, and the functional level of the patient. And that's a useful framework to think about whether to refix or not. The Brighton Group published a similar paper. Again, this is their algorithm for deciding whether to refix or replace. And indeed, it's important to identify the reason for failure. Is there any bone left to refix it? Or indeed, if that's the case, then you could consider revision fixation. If not, you're looking at some form of arthroplasty. I think in terms of deciding whether to refix a fracture or not, repeating the same fixation method over and over again is very unlikely to work. It is critical to identify the reason why that implant failed. It may have not been the correct implant to use for that fracture. So this is an example of a patient of mine who came in. She's 64 years old, but unfortunately physiologically a lot older. She has severe learning difficulties. She has a significantly high BMI, significant cardiac and respiratory comorbidities, and she's a very poor patient in terms of mobility. She has to transfer with 2 and is mostly sedentary, either chair or bedbound. So she had this dynamic hip screw done many years previously. You can see how osteopenic her bone quality is, and unfortunately, following a little stumble, she had a distal femoral fracture, as you can see. So this, as we do in Leeds, we discuss all cases in our trauma meeting with many consultants present, and the decision was to really looking at her physiological function. This was really a pain relieving operation was what was needed, and clearly it was felt non-operative treatment would be very unlikely to succeed. The fracture is very likely to displace. So the consensus was to actually try a femoral retrograde nail to achieve some sort of relative stability, and to avoid the problem of a stress riser, we fixed it with a plate along the side with locking screws in order to give it a slightly more rigid construct. Now, this is an unusual type of fixation. It's not something I'd advocate, but for this patient, it appears to have worked reasonably well, as she's now pain free almost a year down the line, and she is back in her care home and back to her baseline mobility. Total hip replacement, salvage arthroplasty. So when would I consider doing a salvage total hip replacement? Again, host factors, you need to look into whether the patient how frail or elderly with comorbidities. Do remember, total hip replacement as a salvage operation is technically more challenging. It's a difficult surgical exposure, abnormal soft tissues. There may be the presence of broken implants or broken screws. There's likely to be bone loss because of the previous fracture. It's osteoporotic bone, which means it increases your risk of an intraoperative iatrogenic fracture. The soft tissue, especially the abductors, are likely to be insufficient. And there may be non-union causing femoral canal sclerosis or malunion causing deformity. This is a 77-year-old male, previously independently mobile, history of background of hypertension and early Parkinson's. He sustained this left-sided fracture. This was fixed reasonably well with a intramedullary nail with a derotational screw. And, you know, the reduction seemed pretty appropriate. Unfortunately, a year later, he presented to my clinic with a failure of the implant where there's protrusion of the derotational screw, penetration through the femoral head, and the neck has gone to varus, and there's clearly evidence of some non-union. The CT scan here on the right shows evidence of partial union, but also deformity. So again, discussed in our revision complex arthroplasty meetings, which we have weekly. And my plan A was to use a long cemented stem to bypass that whole proximal femur. But I also had a proximal femoral replacement on standby in case that whole proximal bone was unusable in my hands. That's a little cable to prevent iatrogenic propagation of the fracture. It was important to realize that the entry point for your broach and your RAS was different from where one would expect because of the malunion of the fracture, and the canal was incredibly sclerotic. I used a dual mobility socket here because of his Parkinson's, the fact it's a reoperation, and we want to reduce the risk of dislocation as far as possible. So I think it's important to plan well ahead for these patients as far as you can, and to have plan A and plan B, because you really need to get this right first time. The literature would support the role of total hip arthroplasty for failed intertrochanteric fixation. This was a paper showing that of almost 300 patients, 369, showing that actually of those who had a total hip replacement, the length of stay is clearly longer for these patients compared to patients who don't have a total hip for failure. Infection rate is higher, dislocation rate is higher, and the revision rate is higher. However, they do get improvement in their functional scores, and the majority of them still do reasonably well. I've put here dual mobility versus standard socket because I think certainly my understanding of the literature in my hands, I feel dislocation is a worry, and I think a dual mobility socket in these more elderly patients may help reduce the burden of dislocation. This was a paper systematic review looking at about 11 studies, all level 1 and 2, showing that on average, the use of dual mobility sockets for these patients and salvage total hip reduced the dislocation rate from 0 to 5% compared to sort of 8 to 10%. And the Norwegian Arthroplasty Register has published a large series from their registry showing that the role of dual mobility in these cases can reduce your risk factor by about 60%. The evidence, furthermore, these are some papers showing that actually, despite the higher risks and complications, the outcomes for many of these patients is still pretty good given where their starting point is. A lot of them return to ambulatory life, walking, but we also have to be aware that these are high-risk patients. Finally, this is the third case I'm going to present. This is an 83-year-old male, significant medical comorbidities. You can see here, he's got ischemic heart disease, COPD, was previously independent mobile, had a right reverse hybrid total hip replacement, plus some mischief going on in his lumbar spine with fixation. And he again had a failed fixation on his left femur. And I'd again discussed, now his bone quality was awful. So the decision was made to do a proximal femoral replacement straight away. And again, I used a dual mobility socket for this patient. And I'll talk a little bit now about when I would think about using a proximal femur. This is his 1-year follow-up. You can see the huge amount of bone that forms around that left-sided proximal femur, and he's fully ambulatory, walking without aids. So my indications are really, if the proximal femur bone stock is compromised significantly, there is very little you can do with that bone. And I think a proximal femur is often maybe quicker. And for these low demand elderly patients, especially if they've got broken metalwork, which would involve losing even more bone in order to remove, it's important to try and get an operation done quickly that gets them ambulatory ASAP. And I think in my hands, and certainly in our unit, we do use proximal femur replacements for these patients, with the caveat that they are high-risk patients, increased risk of infection, dislocation, and death. And the evidence for this is limited. This is becoming something of a topic of interest, but the functional scores do improve, but the complication rates are significantly higher than normal. So in summary, these are difficult, challenging cases. Get help from your colleagues or more experienced colleagues, certainly. They need individualized treatment. One size does not fit all. You fit the treatment for the patient. There are higher risk of complications, but you can get good function and patient outcomes with hip replacement or proximal femur replacement. Appropriate counseling for the patient and their relatives is critical. They need to know the risks, but also why the benefits of early ambulatory mobilization is so important. I would say consider dual mobility sockets if you're doing hip replacements for these cases, or indeed proximal femur replacement. And I think this really sort of should be done by specialist surgeons, hip surgeons, and discussed in some form of MDT network meeting. Thank you very much.
Okay, Jaya, excellent. Thank you very much. So if I can ask the faculty just to turn on their cameras for this. We'll just go over a couple of the questions, and we'll welcome some questions on the Q&A if you have any more. So, Jaya, you were, I guess, promoting dual mobility sockets, I would say, and you mentioned potentially doing them in your sort of acute hip fracture, total hip replacements. What do the other panelists feel about that? I'll go to Kieran first, and then I'll ask Martin what he feels about the use of dual mobility sockets in hip fracture. Kieran.
Yeah, so dual mobility sockets in my practice is a little bit more selective. I probably should be thinking a little bit more about using them. So at the moment, total hip replacements for hip fractures, I'll be doing a standard hip replacement. But if they have a risk factor such as Parkinson's, then I tend to use a dual mobility, and we have a cemented dual mobility on shelf. So that's what we would use. So it's more selective rather than all hip fractures. But certainly more complex patients, such as the ones we saw from Jaya, failed fixations, I would be thinking in the lines of dual mobility.
Okay, thank you. Martin, can I ask you to unmute and tell me what you think?
Really about the same, yes. I mean, these patients probably got shorter life expectancy, they're less active, so you're less worried about your dual mobility wearing out in the bearings. So, but you're more worried about the dislocation. So, yes, if you're worried about the higher risk of dislocation, then it all seems a good idea.
Okay, so I mean, we have looked at these in the National Joint Registry for total hip replacement for trauma, and I think it's very clear that the early revision rate is lower in the dual mobility, but they do appear to catch up at about 5 years, and we don't know really where it goes from there, but it might be that they fail more often. So it is going to be that balance. There probably is no single answer, I think. So I'm going to go to one of the questions in the chat, and I'm going to address this probably straight to Martin, because he's the most experienced of all of us, I think, at fixing hip fractures. So it's in the young intracapsular neck of femur patient. If a satisfactory closed reduction is not achieved, what's the threshold for open reduction? And have you got any tips? This is from Hussein Taki, and thanks for that question, Hussein.
It's a difficult one. Generally speaking, you should be able to get it reduced closed. And I'm going to admit that I'm getting towards the end of my career and I've not done any open reductions. I've reduced them all closed. The odd one that I've really not been happy with, occasionally I've managed to reduce putting pins and wires in to get it reduced. And there've been one or two which have been old fractures. I thought, let's take them to theatre and see if we can reduce it. I couldn't. And then if we couldn't, then I'll just put an arthroplasty in. But all the others I've got reduced closed. So I go closed and get the best reduction I can. If you can't get it reduced closed, then by all means, a limited anterior approach just onto the hip is supposed to be not too difficult. You open up the capsule and reduce it open. The literature seems to suggest that you will not be improving things. Your overall failure rate from open reduction seems to be higher from open reduction than closed reduction. But maybe that was because the fracture itself was badly displaced in the first place. But you look at the case series reports, is that generally the results are better with a closed reduction. So there's some bias here. The only way would be a randomized trial, and goodness knows how that would be done, but that would have to be it. But the literature is suggesting, if at all possible, reduce it closed. And generally speaking, you should be able to achieve that.
Okay, that's a really good lesson, actually. That makes me feel better as well, because I really worry about doing them open. And I'm going to just ask a question now, which has been actually answered in the chat, but I think it's important for those that are replaying this later. So this is from Deepu Bhaskar. So the role of hip replacement in patients that have hip arthritis and an intertrochanteric hip fracture, as opposed to subjecting them to 2 surgeries. So essentially, do you do an immediate hip replacement? I'm going to ask Jaya what he thinks, and then I'm going to ask Martin just to replay his answer that he gave in the chat. So what do you think, Jaya, if someone's got hip arthritis and an intertrochanteric fracture?
Yes, thank you, Mike. It's a very good question. So one, I think these are difficult cases. I think doing a hip replacement for an extracapsular fracture is significantly more challenging. I do them on a case-by-case decision. If they have horrendous, almost arthrodese hip type patients, then I will certainly consider doing a hip replacement. I think it depends on the degree of the arthritis. It depends on whether they had pre-existing symptoms as well, and what their functional capacity was beforehand. And if they weren't necessarily complaining of any pain, and then I may think, even though the x-rays may show a lot of arthritis, actually these patients are too frail, too old, they need a quick operation, and we deal with the arthritis down the line. If they're pretty well beforehand with symptomatic arthritis, yet an extracapsular fracture, then I may consider doing a total hip replacement. And I've done that a few times in my consultant practice now.
Martin?
Yeah, I tend to agree. It's not a happy situation to be in, going in to do an arthroplasty and find it's a trochanteric fracture. You will not be a happy person doing that, because you think, oh, it's all, what's going on here? There's bits of bone all over the place. It's all falling apart. It's not nice. But there are case series reports of people doing arthroplasties for comminuted trochanteric fractures. It's quite popular around southern Europe, Greece and Turkey and that, to put in arthroplasties. But I'm not happy doing it, really. So I tend to avoid it and would go for the 2-stage. If you've got a little simple 2-part trochanteric fracture, then that's not quite so bad. But if your lesser trochanter's lying off, then you're going to be sweating a little bit as you do your arthroplasty, and I tend to avoid it.
Okay, and I think there is I've got a distant memory of a paper which shows that because of essentially the osteotomy that's been performed, the pain from arthritis often gets better after you fix them. I don't know how true that is, but that is certainly in the literature. So I think we should probably call that in, and I'm going to head back to Vikas now. But I'm really grateful for the faculty for all of their work they've put in and putting those talks together, and for answering the Q&A, and also to those that posted Q&A questions. So over to you, Vikas.
Thank you very much, Mike, for actually moderating this excellent webinar. Fantastic talks based on experience and also evidence-based. And again, this would be in our repository. So if you have been enjoying the weather outside and decided not to join us this evening, then please go on to our Panopto repository and watch this webinar on femoral neck fractures. A big thank you to all the faculty members who've actually given up their time for this. And finally, just to remind you that our next in series would be on the 8th of September, and we begin the 3-pack series of young adult hips now. So the next 3 webinars, it will be young adult hips starting 8th of September. Thank you very much for joining in, and have a lovely week and probably the evening as well, and continue to enjoy the sun. Thank you. Have a good evening.
Bye-bye. Thank you.